But that's, of course, just the upfront cost because it costs almost thousands of dollars more people time, person time to just make sense of all of the variants, all the gene changes that are generated through the sequencing data. And so, but that has concomitantly increased the number of genomes that are sequenced worldwide. And certainly we've heard of many national initiatives to actually sequence large swaths of populations. The Precision Medicine Initiative in the US is an example of this, where they hope to sequence 1 million Americans. And certainly this has spilled over across the pond with the 100,000 Genomes Project in the UK, which is also actually transforming what they're going to be doing in healthcare. And they already have started where it's not just a research project on the side. They've actually infused the sequencing and all of the infrastructure and developed it within the NHS to actually not only develop the infrastructure to connect the sequence data to EMRs, but also train providers to actually on the ground be able to in real time help other clinicians use that type of information to inform care. And this is all very important because if you look at the evidence base to date in terms of trying to support any HTAs and whether we are actually in any position to actually start translating genome sequencing in care, unfortunately, the evidence base is limited. And this spans across all of our sort of traditional pillars of HTA. First and foremost, we just don't have the people power to actually compute the amount of data that's coming through. And our bioinformatic tools and algorithms are still in process very much being developed to handle that challenge. The coverage or the depth of sequence read is also a challenge when you move from exome to genome. So just from an analytic validity perspective, we still have a lot to do. We also, just from the state of the science, a lot of what we generate in terms of the variants that are being generated are of unknown clinical significance. We don't know what they mean for the disease onset and if there is a connection to the disease. And certainly databases are being developed to understand and collate all of the data that we have on variant pathogenicity or the disease association of certain variants, but that's very much in its infancy also. And clinical utility is inherently hampered by our study designs in genomics. The health services research in HTA world with genomics is very much new, and we don't generally design our studies to be RCTs, the sort of gold standards that would meet the thresholds of clinical utility. We often don't have controls or comparison groups, and these are largely just inherent flaws in terms of samples and designs, but also if very few of our variants that we actually can generate from sequencing actually reach a threshold of being medically actionable. That is, that there are clinical interventions available to actually intervene on a disease risk that's been identified through any variants that are generated from sequencing. So it's very often hard to actually address the issues of clinical utility, and Robin, actually in the audience, is actually trying to develop some tools in this domain, and certainly as I go on to share, we're also trying to develop a more rigorous and robust evidence base around this as well through use of RCTs to actually overcome this challenge. The other issue is with cost-effectiveness analyses is the fact that often a lot of the information that's generated in genetics, whether it's sequencing or another platform, is predictive in nature. And a lot of the information and that's valued by patients is certainly just the information for preparing and being informed and being able to plan one's future. And that type of valuable information is not necessarily or regularly addressed or taken into account in our cost-effectiveness analyses. So that's a limitation with trying to achieve an evidence base around cost-effectiveness. And certainly we already know that our current our current cohorts of providers are just not at the current time prepared to deal with current types of genetic tests, whether that is knowing which test to order, how to interpret the results, and how to make meaning from those results in terms of impacting clinical decision making. And there's just survey after survey that indicates that no matter what the specialty, other than genetics, that you survey, providers just don't feel like they have the confidence or knowledge to actually take on the challenge of genetic testing or genomic sequencing. And typical to genetics and genomics is a whole host of ethical policy issues. Consent is always an issue when we're the brave new world of sequencing, but when we're talking about incidental findings, how do you consent someone to receive information for which you don't even actually know what will come through? So a lot of discussion around blanket consent or issues of really being informed is a real challenge in this domain. Equity and access is also a challenge simply because it's an expensive technology. It's not readily available at every institution, and certainly isn't yet in Canada, except for the academic centers that have invested in these, and there's some labs, but there's always an access issue. Duty to read context has become an increasingly important issue because, as I've already noted, most of what we generate from the sequence is of unknown clinical significance. But over time, those variants might be reclassified from being benign or uncertain to something that might become pathogenic over time. But then that has a corollary obligation potentially as to whether a clinician or a research scientist has the obligation to recontact their patients or research participants as new knowledge is developed and as those variants are reclassified to pathogenic or likely pathogenic or benign. And then my focus du jour is really the issue of incidental findings. And this is largely depicted by the fact that every single time a person's genome or tumor is sequenced, there is a possibility of not only revealing the primary purpose of the test, which is identifying the cause of a condition, finding a diagnosis, or targeting a treatment, but the potential revelation of additional variants that are associated with pharmacogenomic drug response, risk for common disease SNPs, unrecognized current disease, which someone might be essentially suffering from some mild condition, but through sequencing, it's revealed that they actually have a variant associated with something that is unrecognized or undiagnosed at the time. There's also the possibility of revealing variants that are associated with potentially distressing disorders, such as neurological conditions like Alzheimer's, Parkinson's, and then I've already spoken to the issues of variants of unknown significance. But other than the scope, the scale is actually quite significant as well. Despite the fact that only about 1 to 6% of the variants that are going to be generated are what we call medically actionable, if there are clinical interventions associated with those disease risks. The actual majority of people that have been sequenced to date have been shown to actually harbor pharmacogenomic and variants as well as carrier status variants. So for every single person that would be sequenced or is sequenced, the possibility of generating this kind of incidental findings actually could range anywhere up to 90%. So let's just put this into context. This is a genome. This is circus plot, essentially presenting a person's whole genome and all the changes within and across the chromosomes. And this is obviously a female. So we have a pointer. There's nothing on the Y underneath the Y area. And this individual came to the genetics clinic in New York, where I was doing one of my fellowships, because she was suffering from breast and ovarian cancer, and there were several cases in her family suggesting a hereditary cause of her condition. So after BRCA1 and 2 testing had shown to be negative, she was offered a panel of a test that tests for several other genes called a panel test, and that also proved to be uninformative. So she was offered genome sequencing at that clinic at the time. And that, in fact, did reveal the fact that she had a mutation in the PALB2 gene, which was shown to then be functional and explanatory causative of her condition and the ones in her family. But what we also had discovered is the fact that she was at high risk for aortic aneurysm, thrombophilia, polycystic disease, and the list went on that I couldn't actually fit onto the slide. And at the time, it was only, a lot of researchers and clinicians were scratching their head as to what we're supposed to do, because we never consented the patient a priori to learn about this information. We didn't know we were going to generate it, and we didn't know what kind of information we could generate. So how could we actually consent that person to learn this information? Kind of what I just described. And with sort of a hot potato situation, we have medically relevant information potentially. what do we do with it? And is there an obligation to disclose it? Well, emerging guidelines internationally have started to suggest, both in the US and less so in Canada, which I will describe, that if you are going to sequence a patient's genome or exome, that you must consent up front to have them, to whether or not they want to learn incidental findings. But they've actually, the ACMG, the American College of Medical Genetics, actually came up with a list of 59 genes and genes associated with various conditions that need to be not only actively searched for, but disclosed to the patient. And so these are considered medically actionable conditions and genes for which there are interventions. And these obligations are not only in the clinical setting, but also in the research setting. A position that came out of our Canadian College of Medical Genetics actually had stated that because of the lack of evidence base on disclosing incidental findings, we should not be doing this at the time, but this policy might be revisited. But you can see that there are tensions with how to handle incidental findings, and there are different variations in terms of guidelines just across the border. But if you ask patients and the public, what do they want to know? Well, the vast majority are interested in learning medically actionable conditions, but also 80% want to know about non-medically actionable conditions. And potentially concerning is the fact that about 3/4 also want to know variants of unknown clinical significance. But the point is that majority, 63%, want all results, and a small minority would want nothing back. But put yourself in this position. You're at your doctor's office, you've tested negative on every single test they've offered you, and your doctor is now offering you a test that is called genome or exome sequencing, but at the same time, he or she is also asking you, in addition to that, do you want to learn a bunch of extra information that you weren't necessarily looking for? How would you weigh up the risks and benefits simultaneously of learning about colon cancer risk, your risk for increased risk for brain cancer, Alzheimer's disease, sudden cardiac death, how you metabolize drugs, whether you are a carrier of certain recessive conditions, your ancestry, and the list goes on. You can imagine how challenging that is and potentially overwhelming for a patient of learning about all of these possible conditions that health risks that might be coming down the line simultaneously, and weighing all of the risks and benefits concurrently. And you can imagine, well, this is a simple solution. Why don't we just get genetic counselors to help sort this out for the patients? We have medical professionals that can deal with this. But there's two problems with that approach. One, we just simply don't have enough genetic counselors, and current wait list to see a genetic counselor at a clinic, it ranges anywhere between 6 to 12 months. And frankly, the current models of taking an hour to two to counsel a patient for one disease and one test isn't really going to translate or scale to a whole genome, and considering a whole bunch of different disease risks and essentially in one test. So what we try to do is address this care gap by developing a decision aid called a genomics advisor, which is meant to provide the upfront education and a values-based clarification to essentially reduce the burden on the clinical teams for whom a lot of this knowledge is actually scarce. I mean, oncologists are increasingly using genome sequencing, cardiologists, and they don't have the genomic expertise or the capacity or the time to counsel patients. So this is one approach to address it. So I'm going to describe the genomics advisor, but first I'm going to let Dr. Mike Evans give you a little bit of the 101 that a patient might see when they open up this decision aid. Stop there. Okay, I'll go on and describe the other three categories. So category 3 is a category composed of rare genetic Mendelian conditions like hereditary blindness and hereditary deafness, watering bird syndrome, things that are probably most general public is unaware of. Category 4 would reveal risks of early onset neurological conditions such as early onset Alzheimer's and Parkinson's disease. And category 5 will comprise of all the autosomal recessive conditions. So after going into the decision aid and learning about what genome sequencing is and all the incidental findings, some of the risks and benefits of doing so, the decision aid would then ask the user, the participant, to then engage in a value clarification exercise and consider the risks and benefits of learning about each category of incidental findings available. And then they go into a knowledge quiz, true-false questionnaire, to just make sure that all of the key concepts are consolidated before they're asked to make a decision. This is part of a larger research program where we first are testing the usability of this decision aid and then evaluating this part of the randomized control trial, which I'll get into in a moment. And then I'll describe our health outcome study and economic evaluation next. So our usability study just describes quickly that we've used the auto decision support framework to develop this evidence-based decision aid. Then went on to test its usability with 15 cancer patients, which is a typical sample size, from largely qualitative work. We had 9 females, 11 of whom were 11 of the 15 were over 50, and 13 were highly educated. So bear that in mind. But what we found with the yellow and the blue bars effectively suggesting good or excellent ratings to the information that was provided in the decision aid, the risk information, the categories, the risks and benefits, and the questions and answers, they were somewhat acceptable. Folks also found the length and amount of information appropriate. They also would recommend the decision aid and were fairly high scores regarding the clarity of information, and all the participants felt that the decision aid was sufficient for them to go on and make a decision. So moving on to our randomized control trial, where we're actually going to evaluate the effectiveness of our decision aid versus usual care, which is genetic counseling. And we selected another cohort of cancer patients who would be eligible at this point for exome or genome sequencing by virtue of the fact that all standard genetic tests until the point at which they get recruited were inconclusive, and therefore sequencing might be diagnostically helpful for them. We also have embedded a qualitative study with a subset of our participants to explore the value and preferences for learning incidental results. These are telephone interviews with a subset of participants across both arms, and exploring largely their decision-making process and how and why they're choosing categories of incidental findings that they are. This is all a hypothetical study. We are not providing genome sequencing to any of these participants in our trial, because the point is to test the decision aid, and the sequencing will be provided in the next phase of our program. So this actually is data that's hot off the press of this week. So I was only able to collate the data related to the preferences, and that's what I'm going to focus on today. So please stay tuned on the outcomes of our RCT in future presentations. So demographic slides are always illegible, so I'm not going to spend too much time, but just to draw your attention to the fact that we have a predominantly female population in our 132 person trial, and that they're highly educated, which is reflective of the fact that a lot of the patients that were recruited from the cancer clinics across the GTA are mostly breast and ovarian cancer patients. I can't describe why they're so highly educated, but certainly that trend was reflected in our qualitative sub-study as well. So here are their decisions. These are the preferences. When we ask them, at the end of the day, going through the decision aid or speaking to a genetic counselor, what is it that you want to learn? And consistent with what we've seen in the literature, the vast majority choose to receive incidental results. Certainly, the top of the chart, we can see that the highest category chosen, most frequent category chosen, is the medically actionable category, and towards the bottom, the next most favored category is the carrier status. There are differences between the two arms, but there you can see that there's also some ambivalence with categories 3 and 4, brain conditions and rare Mendelian conditions, where there's ambivalence in the 50% range, which is probably what you'd expect. But what you can also see is that there's a lot of uncertainty as well towards the turquoise-colored parts of the chart, which is very interesting to explore further research. What you can also see is that many chose multiple categories for both. A third had chosen all 5 categories, and certainly the average is just over 3 categories per person. When we looked at the qualitative data to understand why and what's motivating participant selection of these incidental findings, we asked participants to walk us through their decisions per category and describe what was driving their decision. And category 1, for those that were electing to receive it, it was really driven by this idea that they wanted to control and prevent diseases. For example, I feel I have a measure of control if I can take action to reduce disease risk. But those that interestingly chose not to learn medically actionable information were really focused on the anxiety that was associated with that and drawing on other experience they've had with genetic testing in other domains. I learned my lesson after my oncotype testing. If someone offers me another test, I don't know what that, I don't want to do it. It's because I realize I can't handle the consequence. I can't handle the stress related to it. Category 2, common disease SNPs. The participants that were electing to receive this information spoke about the fact that they would be keen to modify their lifestyles, and this is reflected in the following quote. Knowing this can often give one a reality check or push that they need to be proactive and do something now instead of procrastinating and suffering needlessly. However, others that chose not to receive this information did not see any value in it. I actually have a good lifestyle, I think, so I wasn't particularly bothered. You know, I eat well, I try to keep weight conscious and exercise and things like that. So, category 3, rare genetic conditions. People that were electing to receive this kind of those incidental findings were really focusing on or valuing the aspect of preparation and planning for themselves and family. Gives me a say and allows me to plan for the future event without burdening my children. Those that avoided this kind of information focused on the psychological impact. I would be consumed by the information. It would cause me great anxiety. Early onset brain conditions, those that wanted to know there's these risks in this category, again, focused on the possibility of preparing themselves. I want to make decisions about my care. I want to avoid my family having to go through the heavy love care. I want my husband and my sons to remember me as the happy mom cooking up a storm in the kitchen for family meals, laughing and joking with them. If it were legal in this country, I would decide when it was time to go. Those that avoided this kind of information focused on, again, the negative psychological impacts, but also the possibility of being over-vigilant about any sign or symptoms. No, I don't want to know this because you're going to be forever wondering if it's there. To me, the wondering would kill me. I think it would ruin every aspect of my life because it would totally consume me. I'm going to spend more time sitting in a doctor's office waiting for results of a completely fabricated symptom that I completely made up instead of doing other things in my life. Category 5, participants electing to receive this kind of information from these incidental findings. These types of incidental findings value the idea of prevention, disease prevention, and how it might actually be helpful to share autosomal recessive conditions and those risks. Family members, this one to me is a no-brainer. To me, there is no counterbalance to this decision to do this testing because of the ability to directly impact the life of my child and her children. Prevention through proper screening and intervention, this is the easiest one in my head. whereas those that chose not to receive carrier status results found it immaterial. I'm not looking to have children, so it's immaterial. But what was predominantly, when you look at the overarching motivator to learn incidental results across the categories, what became quite clear is this one driver, the thrust around preserving their quality of life. Whether it was preserving quality of life by learning these incidental findings because of the ability to control disease if possible or prepare practically, emotionally. For example, I got to know everything, and if I can't be treated well, so be it, but what other steps can I do to have a good quality of life? On the other hand, preservation of quality of life was perceived by not necessarily learning these results and not essentially shattering their current worldview, if you will, and by essentially avoiding negative consequences. For example, I think I would just want to know. Well, I wouldn't want to know. It would just drive me crazy trying to figure out, am I going to get it or not? It could ruin your quality of life. So you can see how the value and the motivation here is really in tension with both sides of preserving quality of life by either seeking this information or avoiding it. But the issue here really is, does actionability, the ability that, in theory, having something that you can do to intervene on a disease risk, does that actually imply clinical or other forms of utility? The trouble with genetics and genomics and assessing utility is the fact that on one hand, we have the sort of very obvious ways of assessing clinical utility by measuring a genetic or genomic test diagnostic yield. How often does it lead to a diagnosis? It could also, we can also be looking at we can also measure the impact on care, whether the test results had informed treatment, management in terms of ordering further tests or imaging, or prevention, the uptake of screening or prophylactic surgery, or the adoption of risk-reducing behaviors like smoking cessation, diet changes, and physical exercise. But the other side of the coin that's not necessarily assessed consistently is the personal utility, and that's a sort of a new concept within the genomics and genetics domain of the other types of utility that is actually accrued through genetics and genomic testing, and that's the value of information, whether it's to inform reproductive decisions in the future, whether it's to inform life plans, or to just be able to give your relatives a heads up that this is actually, we're at risk for passing this on to children. So by and large, early meta-analyses and systematic reviews in this domain are starting to emerge, and this is an example from the pediatrics context where they were able to compare the diagnostic yield or sensitivity and clinical utility of genome exome sequencing against microarray, and actually did come to the conclusion that there is greater clinical utility for the technology. But when you look at other forms of clinical utility in terms of risk-reducing behavior, other systematic reviews have actually come to the opposite conclusion, that there's little to no impact on risk-reducing behaviors when looking at smoking, diet, physical activity, and et cetera. And that's largely because of what I told you earlier on. Most of our research in this area are not randomized trials, mostly are not controlled, so a lot of the evidence base isn't necessarily going to be captured in these types of systematic reviews. So we just actually have poorly developed frameworks and designs to actually capture clinical utility and personal utility at the current moment. But most of this research that's actually reviewing literature to date is really focusing on sequencing for the primary reason of the for the primary indication of testing. So sequence, what is the clinical utility or the diagnostic yield of using this test to provide a diagnosis for this cancer patient. There is no evidence to actually consider what the utility of incidental findings have been to date, and broad range of incidental findings just beyond just medically actionable results. So that's actually the aim of our next study that's about to start, hopefully, where we're actually going to be, again, recruiting cancer patients for whom sequencing for whom they're eligible for sequencing by the sheer reason that they've actually tested negative on all standard tests to date. And we're going to randomize them to either the control arm, where they just receive sequencing results related to their cancer, or to the intervention arm, where they learn their primary cancer results along with any incidental findings that they choose to learn using the decision aid that's being evaluated as part of the trial. We're going to be following them for a year through a mixed methods study, looking at health surveys, health service utilization, quality of life, interviews, and measuring all of those, but the primary endpoint is distress. Might be wondering about the economic impacts of disclosing incidental results, and certainly there's a lot of discourse and fear around the potential of quote-unquote raiding the medical commons. You're releasing all of this information, whether it's through direct-to-consumer 23andMe type tests or through genome sequencing. Will there be an increase in the amount of patients that are going to be returning to the healthcare system and asking for potentially appropriate, potentially inappropriate further testing and care based on these results? And will this then drive up costs to our system? And certainly the evidence base has unfortunately come up short. We just don't have the methodology, unfortunately, that is meeting the bar to be suggestive of any sort of cost effectiveness in this domain to be returning primary results from sequencing, and this has been echoed in a more recent systematic review of economic literature. But again, this all focuses on the primary results from sequencing and not the generation and reporting of incidental findings. And so again, we will try to address this gap by linking our health outcomes data and our patients with ISIS to genome cost effectiveness analysis in a relatively short time horizon, unfortunately. But all these findings really point to a lot of opportunities and significant challenges. On the one hand, we have patients that certainly are echoing what we know in literature right now that are super enthusiastic to learn incidental findings. Almost all choose to receive incidental findings when given the option, hypothetical option at this point. And certainly most are choosing multiple categories of results. And from the qualitative data, we are learning that this is really driven by a sense of empowerment to reduce risk and prepare for the future. And from the usability and evaluate and the RCT, Genomics Advisor certainly is starting to stand up in terms of supporting decision making. We can tell from the qualitative interviews that there are certainly highly informed deliberations of the various values that are cutting across a lot of the categories and how they weigh up their preferences for learning, the types of results that they choose to learn from their genomes if they were offered the opportunity to receive incidental findings. So we are certainly feeling assured by that. And of course, whether the tool is effective in supporting clinical delivery is still something that we'll still evaluate through the trial. But on the other hand, there are significant challenges, because the overarching motivation to learn about these results is this idea of preservation of the quality of life. And this really does emphasize the value of information and the non-health related outcomes that patients certainly accrue from genome or genome sequencing, genetic testing generally. But unfortunately, methods to capture this kind of quality of value of information or non-health related outcomes in quality of life metrics or in our qualities aren't necessarily aligned in that way. So better measures of capturing this kind of those dimensions would be really of value to actually possibly show some economic benefit and clinical benefit of this, utility of this information. The notion that patients are adopting broader definitions of actionability beyond those that are just medically actionable, the idea of planning, the idea of being able to, what I haven't shown is data that enroll in a trial, being able to use this information in broader ways than what's been conceptualized as medically actionable, conflicts with what guidelines are considering to be medically actionable results. And certainly in the US, and certainly in most of clinics that are expecting to return actionable medically incidental findings, this would potentially lead to gatekeeping challenges for providers who might be at odds because patients are actually expecting a lot more information than what is going to be disclosed to them. And this raises questions around inequities and access to information. And then I've already spoken about the possibility of over and appropriate use, and this is certainly compounded with the fact that the prognostic and probabilistic information that's associated with a lot of these variants are very challenging for anybody to understand, but changes. And there are inherent uncertainties that need to be addressed, and certainly patients need to be counseled and appropriately use the information, and not, of course, build more value and potentially higher risk estimates in their mind than what should be, what is actually what's there in reality. And I've already spoken to the fact that our current workforce, clinical workforce, is not necessarily up to task to actually deal with the current armament of genetic testing technologies, and this is only going to become worse when we start to start to disclose incidental disease risks and how we're going to, what kind of resources and capacity we're going to have in our system to deal with that. And then the jury is still out whether this actually leads to improved outcomes and any cost savings in terms of being able to like pre-symptomatically identify disease risks that lead to preventative care. So I just wanted to end by thanking some wonderful, very smart people that worked with me in my lab at St. Mike's, and the funders and the large group of wonderful collaborators and colleagues around Toronto, around Canada and the US. So thank you.
So how do you integrate in your research the recent findings from the Personal Genome Project that was published recently? So apparently, like, even healthy people have those very bad genetic variations. So how do you deal with that in your research?
Well, we deal with that by providing essentially what is equivalent to clinical counseling and referral as part of our health outcome study. So we have a study genetic counselor that essentially helps patients understand what they're about to learn and help interpret those results, and then we provide referrals to a whole slew of specialists to help essentially follow up on those results. The difference with the Personal Genome Project, which I am involved with, is that these reports are essentially, they're given lab reports that are not necessarily digested for the public consumption to these individuals, and there's no real interpretation of what those risks mean for and what they're supposed to do with this information. So there is that difference. So it's equivalent. So that paradigm is equivalent to the 23andMe direct-to-consumer testing paradigm, where we're essentially giving genetic test results to people with no support. And so the way that I'm dealing with it in our study, which is whether it's scalable or not is a different story, but it's essentially we're mirroring clinical care and essentially re-embedding the patient with their primary care doc into a larger hub and spoke model where we're going to be shepherding referrals and management with their care team to try to minimize the information falling through the cracks, but also to try to maximize whatever utility and track whatever utilities and outcomes we can. Does that address your question?
Well, it's just the fact that there's mutations that we thought people would not even survive, and we find them in healthy people. So I think it has a layer of complexity for helping the patient make decisions.
Exactly. But that's also what the inherent uncertainties are too, because a lot of our risk estimates based on these variants come from groups that are at high risk, from high risk families, right? From hereditary. We don't need hereditary disease groups. We don't know how that translates to general population. That's the inherent uncertainty that needs to be communicated and counseled, but also tracked. I mean, this is another opportunity to actually identify what the risks, the relative risks are among the general population too. So it's a natural experiment as well.
Really nice talk. And I can think of like 10 things I want to ask you questions about. I'll just confine it to a couple. One is more of an observation that, so there are other areas of medicine that have thought about similar kinds of things. So the cancer screening literature, for example, has thought about a lot of these issues and has a whole like there's this Wilson and Youngner cancer screening framework, which is, which addresses many of the same issues about whether you should go looking for things when you can do nothing about them. And it's substantially more risk averse than the feeling I'm getting from you about what happens in the gene genetics community. It's like you shouldn't look unless there's a big burden of disease, unless you've got a test that works really well, unless you've got a treatment that's highly effective, that's proven. You've got all these criteria about which so don't screen unless you've got all of these criteria. And we don't typically mount sort of very large screening programs like mammography and cervical cancer screening. They've met all these criteria. Other things like ovarian cancer screening have not. So we don't do that. And yet, I get the feeling that the rules are slightly different in the genetics world, where you can sort of look for things even if you have no idea. And the medical imaging world, the analogy would be looking for incidentalomas. Mm-hmm. That it's given it's a strong reason not to image unless you've got a very good reason, because you will find these incidentalomas and then what? So the feeling I'm getting is that in conventional areas of medicine, there is a much higher degree of risk aversion around looking for things that you can't do anything about than in the genetic world. Is that a fair?
Oh yeah, and that's one thing I impart on my students all the time. But I just wanted to, because there's a bit of conflation between screening and sequencing, but this is an opportunistic screen in a way, is what I think that you're challenging.
Well, it doesn't refer to your second issue so much, but I mean, if you are looking for something, and I guess that's not screening either, you're looking to identify the cause of a clinical problem, so that's sort of case finding. But the issues are still related. You're finding information whose significance is uncertain.
Yeah, absolutely, and that's why the American guidelines stopped at only medically actionable findings. Those are the ones that providers and labs have an obligation to search and report, and that's why they stopped only there. But what unfortunately is that there is a bit of not a backlash, but a counter argument from patient groups as well as ethicists and other folks, scholars in the community, is that this is their information, all of it, and no one wants to necessarily be held accountable for information over time that might actually be reclassified and then have to be returned. The other the other aspect that's the tail wagging the dog here is that initiatives like the Precision Medicine Initiative in the U.S. is looking to actually provide all sequence data back in a stick, back to patients, which is inherently the same thing, that people are just going to then go off and try to make sense of it. So it's true that genomics is sort of this renegade where, and it always has been in a way, because we're always this blurred boundary between research and clinic, and we're sort of always moving things in a way, from an HTA perspective, prematurely into the clinic, because we're trying to create the evidence as we're actually developing the technologies and learning about it. And I absolutely agree that argument is part and parcel of the reason why I've chosen this as my project, really, and also pushing the boundaries to the other extreme, which is if patient wants all this information, and if we can provide it in this clinical and research context with as much clinical support as we can, what's the value? And in that, hopefully, if there's no value, we'll actually support recommendations to avoid doing this.
So just one last question. Should we be paying for this?
Exactly.
Archie Cochrane said when they founded the NHS after the war, they said National Health Service should pay for things that are effective and cost effective, and that's it. And, it doesn't seem like we're quite there in terms of public funding.
Yeah. And that's the case when you look at the evidence base across the board for utility of any genetic test. We just don't have, the evidence base to support a lot of these technologies, which is why proponents have argued for this new dimension of utility and are really arguing to bolster that type of justification to support some of these technologies.
I have a question from the online participant. So Petrus is asking, he asked two sets of questions actually, so let me read the first set. Do you think the funding model in a jurisdiction has an effect on the discussion around handling of incidental findings? And how is that addressed in the research around patient preferences and patient perceived value of genetic testing? So that's the first part. Would you want to answer this first? And then
I'm going to have to read it.
Okay. There you go. That's the first part.
Funding model in a jurisdiction has an effect on discussions around handling of incidental findings. Well, first of all, they're not being funded as of yet. Oh, should I go over there?
Oh, that's okay. I think
they're not being funded right now, so we're not currently providing incidental results, at least not in a uniform consistent fashion. Certainly, the Canadian College of Medical Genetics actually advises against it, largely because the labs and the clinical capacity is limited, as it were. So going in and looking for incidental findings is another whole investment in resources and time. But patient preferences do factor into those conversations very heavily, and often can be a very huge heavyweight to those discussions, which is the reason, again, why the whole personal utility dimension of the domain is really being bolstered as another justification for funding this type of technologies.
Okay, so he also has a second set of questions. Do you think patients think the impact of actions due to sequencing, example, high frequency screening on the healthcare budget, for example, in Canada, when they are asked if they would be willing to know of incidental findings, should they be informed?
So that, I think that's one of those ethical questions. If you have no intent to provide something to someone, why offer the hypothetical choice? But from my research, as well as from the literature that we have, we know that if you ask participants what they want to learn a lot. So,
okay. Thank you.
Okay, there's no other questions. I am on time.
I'm on.
Oh, very cool. Yeah, if you want to put this relevant information